Started with our actual content, I would like to go over a couple of quick housekeeping details. First of all attendees have been placed in listen-only mode with your phone lines muted. You can use the chat box at the bottom of your screen to communicate with the group. We'll be using the questions box later to ask and answer questions. Anyone experiencing technical difficulties can email my fabulous colleague Adele at aapiah@ageunited.org. You can see her email on the screen. And I want to let everybody know that a recording of this webinar will be available on our website in the very near future, and we will email you when it is posted. For those of you who aren't familiar with AIDS United, our mission is to end the AIDS epidemic in the United States through strategic grant-making, capacity building, policy, technical assistance, and formative research. So let's move on to this webinar specifically. The goal of today's webinar is to provide you with what we hope will be valuable information about how to involve peers in data collection and evaluation. More specifically, we hope that by the end of this webinar that you'll be able to explain the value of having peers involved in the evaluation process, list some common challenges that are faced by peers who are part of the evaluation team, and describe effective strategies for involving peers in a meaningful way in evaluation, not just involving them, but in a meaningful way. In terms of our agenda, I will provide us with a quick retention and care initiative overview, since that is the initiative that we will be focusing on today. Then Mary Hawk will give us a national perspective on peers and their involvement in retention and care in general, and in evaluation specifically. Then we'll be hearing from two retention and care grantees, Christies Place and the Open Door. And as I alluded to earlier, we hope to have about 10 minutes towards the end for questions and answers, and we will provide contact information as well, so if you have questions either today that don't get answered or come up with some in the future, you will be able to reach out and get those questions answered. So the Retention and Care, or RIC initiative, as I'm going to call it from now on, was a 3-year initiative focused on retaining people living with HIV and care. It was funded by MAC AIDS Fund. And through that initiative, our grantees provided care to 603 people living with HIV. And with the generous support of MAC AIDS Fund, we granted almost $3 million to the field, which I think is a good chunk of change. In terms of the approaches used by our grantees, we had lots of really interesting, innovative approaches, which include navigation and support from peers, which is why we're having this webinar, a housing first model that you'll hear a little bit more about later, trauma-informed care, which you'll also be hearing about, use of smartphones to support retention and care, and all of our grantees focused on underserved populations, including transgender persons, women, children, and families, and homeless individuals. And I should say not every initiative focused on all of those, but those were some of the communities that were served through the various programs. Here are a list of the 7 RIC grantees, again, 2 of which you'll be hearing from today. And 5 out of 7 of them involved peer navigation, peer support within their program. Because we'll be taking a look in more depth about peer involvement in evaluation, we thought it would be helpful to hear a bit about the RIC National Evaluation so you have a context for what we're talking about. I'd like to start by acknowledging our wonderful evaluation partners, Drs. Kathy Mosby and David Holtgrave from the Johns Hopkins Bloomberg School of Public Health, and to share with you the goal of the national evaluation, which was to aim to answer at the national level cross-cutting questions about retention and care, and that included identifying people who are out of care, how to link folks to care, how to re-engage them if they'd fallen out of care, and to help them stay in care. And the point of all of this was to inform current and future programs, and then also to speak more broadly to successes and challenges of the healthcare system, and to inform policy as well. In terms of the national evaluation design, there were lots of things that they were measuring, including client-level outcomes such as changes in CD4 counts and viral loads. Please excuse the banging that's going on behind us. We have workers working on another floor of our building. We also looked at social determinants, needs, and barriers to care. And the team also conducted an economic analysis to look at cost per client and cost effectiveness and savings of the various programs. And probably most important piece of context here for what you're about to hear is the slide, because it speaks to the enormous contribution of frontline staff, including peers, in the national evaluation effort. Each grantee site collected client-level data every 6 months, which meant using standardized tools to get data directly from clients as well as from other sources such as medical providers and databases like CareWare. And as I mentioned before, because 5 out of 7 RIC grantees employed peers as frontline staff, peers naturally became involved in evaluation and data collection. So to give us some big picture perspective on peer involvement in the RIC evaluation, our next presenter, Dr. Mary Hawk, will talk about a research study she conducted to look in depth at the experience of peers in general and with evaluation specifically. Mary is currently assistant professor at the University of Pittsburgh Graduate School of Public Health, Department of Behavioral and Community Health, where she has been on faculty since 2012. She's also worked extensively with nonprofit agencies, including the Open Door. Her nonprofit work has centered on HIV/AIDS direct services, grants management, and organizational leadership. Dr. Mary Hawk, please take it away.
Well, thank you so much for the intro and for including me in the webinar. And I'm especially honored to be a part not only of the RIC initiative, but also to be sort of standing next to Erin and Christina and Nate and Jay, even though she couldn't be with us today, because you guys are all doing such important, critical work. And I'm pleased to be doing this with all of you. So probably lots of people on this call would acknowledge that peers are state of the art and really the way to go when we're designing interventions for people who are living with HIV and AIDS. And there are lots of studies that have demonstrated that programs that rely on peers can help to reduce HIV risk and also improve HIV health outcomes. In addition to published studies about these outcomes, there's also a lot of community wisdom that acknowledges that peers can really make effective changes when it comes to engaging people in care. So peers work because they can connect with community members based on their shared characteristics and experiences, and this is especially true for members of communities that are often marginalized, as the people you see on this slide. So peers have really been at the forefront of the fight to end the AIDS epidemic since the very beginning, with organizations like ACT UP. So I'm one of the founding board members of the Open Door in Pittsburgh. You'll hear from Nate and Christina later. But I got involved in this study because when we got the RIC initiative, we were truly honored not only to be able to expand our services through that grant, but also develop our evaluation capacity. And it made sense to us from the start to have our amazing peers be the people to conduct assessments with clients, because those peers have the best connections with our clients. However, this was a challenging process. I'm sure we'll hear more about that from Nate later. And we realized early on that we were probably making some assumptions about how easy it would be for our peers to collect these data and whether or not that really made sense. So in talking with AIDS United and Kathy Mosby, it became clear that we weren't the only programs that were questioning these issues. And we decided to conduct some qualitative research to explore the kinds of evaluation activities that were being done by peers and what challenges they were experiencing, and most importantly of all, the benefits of peer-based evaluation, as well as some strategies for addressing the challenges that they experience. In the summer of 2015, I had the honor of interviewing managers and peers from the 5 grantee sites that were not only using peers as interventionists, but also were using peers to collect data. So this was such an incredible experience for me because I got to see the amazing commitment of peers and staff members all across the country who were doing this really important work. And there were some great programs out there. Through these interviews, we learned, so now I'm going to move into the results section of my brief presentation, and these are the results that we learned from the qualitative interviews. We learned, first of all, that peers were indeed involved in not only service delivery, but also lots of evaluation activities, which included conducting client assessments, completing client follow-ups, as well as data collection and data entry. And I think it's safe to say that it feels a lot of times like peers do it all. We also learned that the assessment process, as was mentioned earlier, was hard for a lot of us. As part of the RIC initiative, we collected multiple evaluation variables, and many of the local assessment tools that I saw were between 10 and 15 pages long. This was very challenging because those client assessments took time away from service delivery and also brought a lot of trauma to the surface for both peers and clients. It was addressing a lot of questions that had to do with past trauma and stigmatizing experiences, so it became very challenging. The work of peers is already challenging because they're so committed to our clients, but adding evaluation activities, I think, further stress their caseloads. Part of the problem, I think, is that for our peers, it can be hard to turn it off, right? So their days didn't end at 5 o'clock. They were available to clients at all hours. And this is because they wanted to be available to clients at all times. They'd been there in many cases, and they wanted to make sure that our clients are being supported. But this also means that self-care came last for a lot of our peers, and I think that's something we need to make sure we're paying a lot of attention to. So this was further challenged by the fact that clients were reassessed every 6 months, so caseloads keep expanding. That means that you could work intensively with a client for 6 months, but still follow them up for 12 or 18 months, which means they were active on the caseload for that entire time. And I'd like to share this quote with you from one peer. I'm going to give you a moment to read this rather than having me read it to you. It's going to be awkwardly silent for a moment while you go ahead and read, and then I'll catch back in. And so I think this is a great quote. It sums up that idea that there's this never-ending caseload of re-engaged clients. Many of the programs may have designed interventions that lasted or worked intensively with clients for 6 months, but then we had to keep them in care for that whole 18-month period to make sure that we were able to conduct follow-up assessments with them. And here's another quote that I just find to be so beautiful and really sends a message home that our peers take on a lot. I will say that there was a sense of awareness that there were staff members and peers all across the country through the RIC initiative that were working sort of on the same problem, keeping people in care, collecting data. So I did feel like there was a sense of connectedness when I spoke with people, and also a sense of understanding that when you're a peer worker, you get more and more work and never less and less work. But there are also benefits to having peers be the point person for data collection, which include the fact that clients are probably a lot more comfortable sharing personal information with peers, and that makes them more likely to complete follow-up assessments as well. So here's another quote that speaks to that idea that clients will talk with peers more readily. So another thing that emerged from these qualitative interviews is that we need to be careful about data collection. This data collection process was very rigorous, many variables collected, which is important for us to sustain our programs. And everyone spoke very clearly about that, the fact that we need to have tight, rigorous data to not only demonstrate our outcomes, but sustain our programs. But peers could sometimes struggle with this balance between rigorous data collection and the comfort of their clients. And here's one of my favorite quotes about that. Whoops, I'm sorry, I jumped 2. It's one of my favorite quotes about that idea of asking clients to share a lot of information. The challenge here is that because the assessment tools were validated, it means that some of the questions or evaluation variables were asked a couple different times in a couple different ways to make sure that we're getting the same data consistently, and clients sometimes felt that was redundant. Furthermore, coming back every 6 months to complete the same assessment felt like a lot of work for clients and for the peers that were doing the assessments with them. A number of strategies to strengthen peer-based evaluation emerged, as you see here, and I think the main things are that training is critical and needs to happen over time, not just at the beginning of the study period. It's not just a one-and-done deal. We can talk with peers about how data needs to be collected. It needs to be a continual learning and problem-solving process. And as part of that, we need to find ways to make it okay for people to not just ask questions, but also to report when they're going off protocol. So they're not being penalized, but also as part of this continuous improvement process. So there needs to be a way, if someone is having, any staff member, but particularly peers, if they're having trouble recording data accurately or getting information from their clients, they need to be able to share that and get support around problem solving those issues. And finally, I think it's important to be intentional about this idea of other duties as assigned, these things that get loaded onto the plates of peers. Because I think that we can make assumptions about little bits of work are not too much, but those little bits pile up and become lots and lots of work. And we really need to be careful about glossing over the time and energy the data collection requires. So I'd like to conclude with just a few last-minute thoughts, and I don't want to sound preachy about this because it's certainly very apparent that all of the grantee sites that were participating in this project were very invested in their peers and honored their work and understood their value, and no one was taking them for granted. But I think that when we work in aid services, we're all in this sort of get-it-done mode all the time, and it's easy to slide into habits of adding responsibilities to people's workloads without really exploring what that means. So as part of that, I think it's important to say that while peer-based assessments might increase the comfort of clients, it's really the program that benefits from the work rather than the peers or the clients that are right in front of us. So of course programs benefit over time when we collect rigorous data, but the person who's sitting right in front of us, there may be a cost for them in terms of their comfort or the stigma they can experience when they're being asked questions about their histories again and again. The value of peer-based evaluation to the program and the peer and the client really needs to be carefully weighed against the potential costs. And this decision-making process creates a paradox because we often rely on peer workers to improve outcomes for clients, but the benefits that sometimes those benefits can come with a cost to the peer workers themselves as well. So again, in no way am I saying that we shouldn't be doing peer-based evaluation. I think there are many, many benefits of to this process. But I also think that there needs to be some clarity around how to protect peers who are doing this work in the process. And as part of that, I would just like to say that we can't forget that when we're thinking about improving the lives and outcomes of people living with HIV and AIDS, that also includes peers who are living with HIV and AIDS who are working in paid positions. So I think that's all for me. I'm going to hand it over now to Christies Place.
Thank you so much, Mary. That was very helpful for context, and the quotes really made it especially rich, I think. And as Mary said, next we are going to hear from Rick grantee Christies Place about their experience with peers and evaluation. We were hoping to have two presenters from Christies Place today, but unfortunately Jay Blount, peer navigator, was unable to join us, but we do have her slides included, and our next presenter, Erin Falvey, will be going through those with you. Erin is the executive director at Christies Place, which is a nonprofit organization in San Diego, California that provides comprehensive social services closely linked to primary care for women, children, and families living with HIV/AIDS. Erin is a licensed marriage and family therapist and has been practicing psychotherapy since 2004. At Christies Place, Erin oversees the development and implementation of gender-responsive, trauma-informed clinical and supportive services focused on access to and retention and care for women living with HIV, which includes behavioral health, medical case management, peer and patient navigation services, and the Change for Women program. Erin, please take us away.
Great. Thank you so much for having me today. It's really an honor to participate in this webinar and share some work that has been just tremendously impactful here in San Diego County, and I'm hopeful that all of you can take from some of our lessons learned to build your own peer programs or enhance your own peer programs. So Christies Place has been around since 1996, and our mission is to empower women, children, and families whose lives have been impacted by HIV and AIDS to take charge of their health and wellness. For over 20 years, we've filled a critical need for gender-responsive, family-centered, culturally and linguistically competent services which address the unique needs of women, children, and families impacted by HIV. We've started out as a small grassroots organization, and we've grown into a comprehensive social service organization, and now we receive about 25,000 visits annually. We're a small organization. We only have about 17 staff, and our services include an early intervention services drop-in center, medical case management, behavioral health, family casework, peer navigation, support groups, and annual events for our families. So our retention project actually built upon and was expanding an existing program that was funded through AIDS United and the Social Innovation Fund, and that program is called Change for Women, and that was launched in 2010. And Jay, who was introduced earlier, actually has been with the program since the start. And so we actually had a few years of evaluation and data collection with peers under our belt before we started the retention project. And in 2010, the Change for Women project really involved the integration of peers as key treatment team members at Christies Place. Change for Women was developed to address the structural, provider, and individual barriers that women living with HIV face, which fuel gender-related health disparities. And what we learned in the first 2 years of the program was that the strategies we were utilizing were really effective to identify women who were newly diagnosed, really effective to identify women who were not in care, as well as women who were at risk for falling out of care. And we did a great job of linking over 250 women to care. But however, through those years, we also learned that we really had to expand our focus from linkage and access to address barriers for women living with HIV, the barriers they experience in retaining care. And because we know that trauma and PTSD predict poor HIV-related health outcomes, including inferior health-related quality of life, lower rates of ART adherence, and higher mortality rates, we expanded our programmatic focus through the RIC project to explicitly address the effects of interpersonal violence and victimization on a woman's lived experience in order to improve healthcare engagement and health outcomes. So the first piece of that was creating an agency-wide shift towards trauma-informed service provision, as well as trauma-specific interventions. For those of you who may not be familiar with what trauma-informed approaches are, trauma-informed care is a resilience-focused and strength-based approach to service provision that involves understanding, recognizing, and responding to the effects of trauma. And then specifically, some of our strategies for the RIC project were our retention and care treatment team, our retention and care barrier assessment, the first of which was implemented by the peers, and then we had a larger assessment that our mental health counselors engaged in, our trauma-informed client orientation, behavioral health services, medical case management, of course, peer navigation, treatment adherence activities, and domestic violence support groups. And really, because the meaningful involvement of those with lived experience is a key component of trauma-informed model, and when we're talking about lived experience in our program, we're talking about lived experience of violence and abuse, we're talking about lived experience with HIV, lived experience with mental health concerns and substance use. So our peers really have a lot of ways that their lived experience helps to create connection with clients, but that also that's the key component of how we think about the work here at Christies Place. So in addition to patient navigation, our peer navigators were also enlisted to co-facilitate our support groups. They also participated in the treatment team and conducted the trauma-informed client orientation and retention and care barrier assessments. So our peers do a lot. Their work is tremendous. So in addition to evaluation, which if many of you have participated in research or programmatic evaluation projects, oftentimes there's a person who's just tasked to do evaluation. So our peers are providing a lot of services in addition to evaluation activities. I also think it's really important to note that they're paid full and part-time staff members, and that's always been very important to us that we are able to bring peers on as full-time paid team members. And these are the activities that our peer navigators engage in. Community outreach and case finding, They assess and address barriers, including psychosocial needs, and then our local and national indicators were a part of those assessments. They do home visits. They accompany clients to their scheduled appointments, including medical appointments, legal appointments. One of our partners through Change for Women was through a legal organization, particularly for women who have legal status issues related to violence, and that's particularly important for us being a border community. They also transport clients, do translation for clients, substance abuse counseling, emotional and peer support, health education, healthcare navigation, of course, information and referral, and then also do a really good warm handoff to our case management and trauma responsive behavioral health services. And so, like I said, that's a lot. Those are a lot of activities to engage in, and then to have the pressure and the weight of the local and national evaluation added on top of that required a lot of support. And so the peers are supported in these activities through initial orientation. They also participate in the 5-day Lotus Peer Advocacy Training, and if any of you all are interested in more information about that, please follow up with me afterwards. But it really orients peers to peer advocacy and peer work, teaches about motivational interviewing, creating boundaries with clients, setting goals, HIV 101 education. So it's a really great training. They also engage in ongoing training on topics related to trauma-informed social service provision. And one thing I think is really important is that they engage in weekly clinical supervision with a licensed therapist, as well as weekly administrative supervision to support quality management of data collection. So now I'm going to talk, let me back up just a second. I wanted to share some of the successes, challenges, and lessons learned. There were a lot, but I'll be brief about it. So one of the great successes is that the Peer Navigators piloted our risk barrier assessment, which briefly assessed for PTSD, substance use, depression, anxiety, safety, and trauma history. And I think that the peers really proved that this type of assessment could be successfully conducted by a non-mental health staff member. And now we utilize that assessment agency-wide with all of our clients to better identify potential retention barriers. And the peers actually really guided the rest of our staff in how to best ask the questions related to PTSD, safety, and really dispelled some of the myths and the fears that our other staff members had about asking those types of questions, and really role modeled how best to do it. So I think that was really exciting. Also, our peer navigators quickly develop rapport with our clients, and therefore our clients are more readily disclosing of sensitive information to them, which I think served a dual purpose of tailoring service provision and data collection. One thing that's really important to me is that I don't think we should ask a question ever that doesn't have a treatment planning or service provision aim in mind. Sometimes it's a little harder to find that, but I think that we really had to, and this is a lesson learned as well, we really had to talk through all of the evaluation questions as a team and process what the meaning to the client and the value to the client of asking any one of the questions that we were asking. And if we couldn't find one, when we were developing the protocol with Johns Hopkins, we gave that feedback. And so we were able to really develop an assessment protocol that felt meaningful to our team. Some of the challenges. So the project was designed as an evaluation rather than a research study, and so it really had all the challenges that could be expected in real-world settings. Client follow-up was really hard, particularly given our large cohort, and SIF it was over 250, and the Retention and Care Project had 115 clients, and only 3 peer navigators to follow them for 18 months. Also, one of the biggest challenges, which I also listed as a success previously, was that utilizing peers both in the role as providers and as data collectors. Because that requirement for data collection exceeded the client's need for intervention at times, there were times when the client was really ready to launch from our program, but they still met with their peer every 6 months for follow-up. And I think that kind of created some confusion for clients about their role in the program and their role with the peer. Was the peer still a service provider for them? And I think that created some challenges with boundaries, and also with clients feeling like, wait a minute, where is my role, and am I still needing this level of assistance, or am I not? So additionally, the peers really didn't have any training in evaluation prior to the project, so they needed a lot of support from staff to track the assessments that were needed. And like I said, we had 115 clients that were participating in the retention project, and we were following them over 18 months. And we had 6-month windows with or windows of 30 or 90 days in between, and it was very complicated. So we really had to develop a pretty sophisticated tracking tool to make sure that we got people in when they were supposed to come in. And the data set was just massive. It was huge. So I think that lessons learned, I think that it's really imperative to have strong clinical supervision with a licensed clinical staff member, as well as administrative support in place for peers. I really think that that's true of any type of project, and with any staff engaging in collecting sensitive data, but I think it's particularly imperative for peers. And then, so as Melissa mentioned, Jay wasn't able to be with us today, but we sat down and kind of looked at the different types of questions and what she wanted to impart to you all. And so her first thing was, what was your initial reaction, Jay? And Jay will tell you that she was so excited to come onto this project and felt that Change for Women was exactly what women in San Diego County needed. At the time we started the project, 69% of women living with HIV were known to be out of care. And at this point, we're at about 42%. And so I think, and our county has publicly acknowledged that Change for Women has helped to do that. So she said, this was overwhelming, confusing, and uncharted territory for me. And Jay is a person who will say, if you don't document it, it didn't happen, and we need to raise up the voices of peers and the importance of this strategy, peer navigation. So I think that she really got it from the start and helped to mentor our other peers in how important it was to follow the protocol and to get all of the data that we possibly could and to input it, because I think her vision was really that we were advancing the field with peer navigators. So she said that some of the successes were that we gained valuable information to help guide our work. We learned how to do data collection and got really good at it. And I think that our peer staff were really, really proud of how good at it that they got. And then a piece that was really important, and I think it's been really valuable to have 3 peers on staff, is that they all back each other up. They each got to know each other's clients, and so if someone was out because they were ill or on vacation, and another client's assessment had come up, they would meet with each other and discuss it beforehand and make sure that we got all of those in so that we got it in time based on the requirements for the national evaluation. They had a lot on their plates to balance between the assessments and providing services, and so they really just supported one another, both in the work and emotionally. And then the challenges, as Mary mentioned, the local and national evaluation tool was really lengthy and really time-consuming, and it contained a lot of sensitive information. And so it wasn't like you could just roll through these questions and move on to the next. They really had to balance their role as service provider and sit and process some of the answers and the implications of those answers. And so sometimes it would take hours to get through the evaluation questions. Getting people in, 6 months, 12 months, 18 months, and then keeping track of those assessment windows was really challenging. Their caseloads were huge, and that was an important lesson learned for us. And then it was also really hard for us to get medical visit and lab data. That was another piece that the peers were tasked with, because there was a component that looked at missed medical visits as well as viral load and CD4 count. And so because we're not a clinic, we don't have ready access to that information, and we have clinics all over the county that provide medical services. So we're constantly sending out faxes and making phone calls to get that data and inputting that data, and that was very time-consuming. And then lessons learned. So we refined our peer navigation assessment to be more specific to the intervention, and we actually have a new 4-year study engaging peers that we're just starting called Empower Women through UCSD, or in partnership with UCSD, that will utilize peers and a trauma-responsive evidence-based model called Skills Training in Affective and Interpersonal Regulation. And the peers will actually be implementing part of that, and that's traditionally only been utilized by mental health professionals. So we're really excited about that. So our assessment is more specific to the intervention, and the new study is going to use a research coordinator to gather the data that's less relevant to the intervention so that the client has a clearer understanding of their role with the peer. So any assessment items that are really related to the intervention and the actual model, the peers will engage the clients around, and then questions that are less relevant will be introduced by the research coordinator as something that's contributing to the larger project. And we're really hoping that that's going to help delineate roles and clarify boundaries. The other thing we learned was the intervention works, and that we really have to have strong relationships with clinics and medical providers in order to keep women in care, to get the data needed, and to successfully engage in the programmatic evaluation. So I think that is all that I have to share today. Please feel free to reach out to me if you have other questions or at the end of the presentation, and then we'll turn it over to the open door.
Thank you so much, Erin, for sharing this information with us today and for all of Christies Place's great work throughout the RIC and also SIF initiatives. Now we're going to hear from another standout grantee, the Open Door. And in the interest of not interrupting their presentation, I'm going to introduce both of our Open Door presenters before they get started. So first we'll hear from Cristina Formartino, who is the Executive Director of the Open Door Incorporated, a local nonprofit that is dedicated to serving chronically homeless, high-risk individuals living with HIV. She also previously served as the Interim Executive Director of Prevention Point Pittsburgh, a nonprofit that is committed to preventing the transmission of HIV and hepatitis, as well as overdose fatalities among people who inject drugs. After Cristina, we will be hearing from Nate Williams. Nate is a program manager and linkage facilitator at the Open Door. He has previously worked as a case manager at the Onslow County Health Department and has served on several HIV prevention community planning groups. There are lots of other interesting tidbits I could share about Nate, but in the interest of time, I will share just this one. He is currently writing a book titled It Could Even Happen to Me, which is about his life as a preacher's son living with HIV and the stigma he has experienced. So let me hand it over to Cristina and then Nate.
Great. Thank you so much. We're so thankful to be here and be with on this phone call with our amazing partners and everybody that has joined the call. I'm going to try and be as brief as possible so that we can get to Nate and hear his perspective. And I know he has some really good information to share. So it was already mentioned kind of what we do, what our mission is. So essentially we provide supportive housing and related services to improve the health outcomes of individuals living with HIV. And what I love about the Open Door the most is that it's the mission possible, as I would say. So our board, our peers have really demonstrated in our residents that housing does work and that you can do it on a budget. So our program was run under a budget of $40,000 for the first 7 years, which is why a part of the reason why we were connected to AIDS United and a part of the reasons why we entered into the Retention and Care Initiative. So the first reason, or the first thing that we did with the Retention and Care Initiative was to move Nate and promote him to the linkage facilitator. He was already the program manager. He's actually been with us since day one, as well as hire our first executive director. And we also plan to replicate our model in other cities to show that housing does work and that it can be done in cities larger and with higher costs than Pittsburgh. We also expanded our representative payee services, which is our second program in addition to our housing. A representative payee is essentially a person or an organization that receives Social Security or disability benefits on behalf of an individual and then helps them pay their rent and utilities and save or spend the rest of the money. What we found is that this reduced the financial chaos and stress in people's lives so that they could focus on their health care. In our most recent study, a pilot study of individuals who are accessing our representative payee services, at initiation, about 33% were virally suppressed, and at 6-month follow-up, 88.9% were virally suppressed. So this is one of our programs that we expanded through the Retention and Care Initiative, and a lot of the people that we utilize peers to collect data for. As I mentioned, we replicated our model and worked with 2 organizations in Youngstown, Ohio, and Philadelphia, Pennsylvania, the first of which was Ursuline HIV/AIDS Ministry. They purchased their own building, renovated it, and are already housing 4 individuals and plan to expand and work with the city to create more housing programs. So we follow 3 specific models, first of which is housing first, which means that we prioritize housing over all other treatment goals. The second of which is harm reduction, meaning that we create a safe, non-judgmental environment, and that we do not keep people out of housing if they are currently using substances. We work with them to help reduce the risks involved, but we understand that people can be successful in their lives even while continuing to use substances. And the third, which is the most important, and the reason why we're all on this call, is our peer model. So this is Derek, Nate, and Yvette. And as people have already mentioned, what our peers do is very similar. They help essentially to our clients to navigate the local healthcare and social service system. So they were tasked with the large duty of collecting all this data and working with our residents and participants. And a lot of the challenges that we found were that it was an enormous amount of work, as Mary and Aaron both alluded to. It really created a difficult struggle, I think, for our team, because we had to collect all this data, which was a benefit to the program and to learning more about our residents so we could better serve them. But at the same time, it was distracting from serving them in that purpose. So it was really eye-opening to us. And, Mary, again, had spoken about this earlier, but we hired our peers because of their lived experience and their tremendous connections and ability to work with our residents, but it distracted from that work. It was also eye-opening to us and created a lot of conversations around self-care. So we focused a lot on burnout and, the trauma that you learned about in these interviews, and a lot of the details that we got made us focus and have us try and prevent burnout and try and focus more on a trauma-informed and strength-based model. Another eye-opening thing for us was the training piece of it. We know we keep adding and adding work, and with funding comes more work, but sometimes we forget to focus on the training aspect of it. So we've made a plan to do more training and more brainstorming. This is a brainstorming session that we did so that we're all working together and collecting the best amount of data that would help the program, but also supporting our peers in these processes. So we had a lot of successes as well. We got the most accurate data because our peers have built such trusting relationships with individuals, and that really helped them to shape their service plans with individuals. It helped us definitely get prepared for additional and higher levels of funding. We created a data and access database out of this project so that we could better track the information that we were getting. And and it also just helped us get the most meaningful data from the people that we were working with. So I love this quote just because it always makes me think about, the question of involving peers in work is complicated because it brings up a lot of challenges, but the answer is really simple. Our peers have the best relationship with our clients. They're so integral to our programs. success, and I think the simple answer is that we need to be more responsible about providing the training, support, and also the feedback regarding the data. I think that was another challenge of ours, is then taking that aggregated data that we got to share it with the peers so that they knew the success they were having with clients. So with that, I'm going to turn it over to Nate.
Hello, everyone. First of all, I want to say I'm so honored to be able to share my view in data collection. So my personal goal with data collection, I found, was to breaking the chains that have kept people from accessing the care, not only collecting information, but seeing and identifying what has kept them where they were not getting care. So I found out there was a lot of hard questions for myself, and especially the client that we were asking. So I think how the questions were read is a way to get better success. I found out that even one of our clients fell asleep while I was asking the question. So they were hard questions to ask. So one thing I did find out was that there were other challenges as far as we were collecting some very personal information, and they were concerned about where is this information going, who's going to receive it, what is the confidentiality policy as far as collecting information, was it going to be secured, or can someone get a hold to it? And that was one of the challenges when you are collecting data, because the stigma is already upon them, and then their information in the midst of that stigma was a great concern. So we discovered that, I discovered that my relationship with the clients was able to get the most accurate information to better serve the client. I discovered that because of the trust that we had built prior to this data collection was one of the foundations that we were able to build continued relationship and to ensure that the information we got would be given to the right proper authorities and we can better serve them in the future. One of our strengths, or many of our strengths, we found out that the Giant Eagle gift cards was one of the eye-opener, attention getter to get the information. And the one thing I found out, it wasn't so much the Giant Eagle voucher, but the trust that we had. We got the information and we were able to give them a thank you for the information that was so valuable, where they were able to get groceries, cigarettes, little items that would help them. So if there's any questions, we're available.
Thank you so much, Nate and Christina, for sharing your experience with peers and data collection and for all the work you did on the RIC initiative. And as Nate said, we are ready to move into questions and answers. If you do have a question, please go ahead and we will read it out loud so that everybody can hear it, and then we'll open it up for presenters to answer. Please do also make a note if there's someone specific you would like to answer the question. And let me specify that the question box is to the right of the PowerPoint slides, right under the Age United logo. questions? Anybody? Somebody must have a question for these fabulous presenters.
I actually can see some questions on the side. It looks like Mike Hellman asked, how did you recruit peer navigators to apply to these positions?
Oh, thank you so much. For some reason, they're not appearing on our screen. I appreciate
Sure.
you reading that.
I'll type them into the chat.
Okay, how did you recruit peer navigators to apply for these positions for Mike Hellman? Who would like to take a stab at that one?
This is Erin. So we have always worked at Christies Place. We've done a lot of work around leadership development and advocacy training. And so it's interesting that both Jay and Martha came to us, who are two of our peer navigators that have been around since the beginning of both projects. We sort of had our eye on noticing how they were already working in the community to influence people. And we had our annual women's retreat and really just saw a lot of leadership from each of them in guiding newer women who are a part of the retreat and really partnering with and fostering relationships with them. And so when we received the funding to start the project, we really, were able to identify both Jay and Martha as women who were strong candidates. Martha had already done the Lotus Training and Jay did it subsequently. And so they were really natural fits for the project. But neither of them had had training in social service provision or evaluation previous to that. So we did a lot of work in mentoring and training them as they started.
Thank you. And this looks like another question for Erin from William Scott Daly. Are you able to do outreach to the military bases in San Diego?
We are able to. We don't do a lot with it. One of our former peers, Heather, actually was former military, and so she had a little bit of inroad, but it's not an area that we're able to do a lot with.
Okay. Thank you.
This is Mary. Can I jump in on the last question?
Oh, please.
So I just wanted to echo what Erin was saying, which is that most of the sites I worked with or I interviewed had identified appropriate peer interventionists because they were individuals who had been clients at their organizations first and demonstrated, as Erin said, great interpersonal skills, great leadership skills. But I also want to point out that a peer is not always a peer, right? So many peers in this field are people who are living with HIV and AIDS, but sometimes I would interview peers who had other common characteristics, like maybe they have part of a smaller community, like perhaps a Latino community. Sometimes we see peers who are working in that role because of their history with substance use. But I think it's interesting that we do typically, I think in this field, tend to identify appropriate peer interventionists based on the fact that we're seeing them as clients. But it's interesting, again, as Erin said, that we're hiring for those interpersonal skills, social skills, and then asking them to take on evaluation activities, which does not mean to say that they can do both. But I believe that when we come from more traditional professional positions, we make some assumptions about our abilities to do data collection, data entry. And by no means do I mean to infer that peers can do that work. I just think that we need to be clear about the fact that we hire them for one thing and then ask them to do something else in addition.
Absolutely. Thank you. Okay, we have a question from Bill Kubicek. I hope I'm pronouncing your last name correctly. Was there any difference in success when working with young adults or youth?
So our program, the youngest person who participated was 18. And I think that there were different challenges. I think that the oldest woman was in her 70s. I think that we just saw, that there were differences related to age and things that women were navigating if they had children, if they were caring for grandchildren. But I didn't see any differences with success across age ranges.
How about the open door?
So I would just echo what Erin said. We also don't work specifically with youth, so probably the youngest in our cohort was 24. And we didn't see any significant differences in success.
Okay, thank you. Mary, did you have anything you wanted to add from your research?
No, I would second and third what Christine and Aaron said. At the Open Door, our average age of people we serve is in the 40s. So we don't have a broad range of data there.
Okay, great. Speaking of data, Natalie Slough is interested in knowing, do you have the summary sheets of the methodology for both the evaluations with results? And I think to some extent that's a question for Age United, but I'm wondering, let me ask the Open Door in Christies Place whether you have something locally that you're willing and able to share that speaks to your incredible successes.
I think the most, this is Mary, I think the most appropriate or most helpful, I should say, piece of information might be the manuscripts that Kathy Mosby is going to be hopefully releasing soon. I think they're under review right now, but that would give us probably the best overview of success across the RIC grantees.
I would agree with that.
Yeah, so thank you for that. And from the national perspective, we at Age United are working on some what we're calling legacy web pages for both the retention and care and a closely related initiative, the Access to Care Social Innovation Fund initiative. And we will be including some key evaluation findings for the overall national cohort on those. So I would say to please check back on our website frequently to see the new and hopefully very useful information and tools we will be adding. From Denise Smith, we've got a question. Is there a way for other peers to get involved? And I am taking that might be a question about whether there are additional peer opportunities at either of your organizations at this time. And Denise?
Christies Place will be, if someone is local to San Diego, we will be doing the Lotus Training in the next couple of months. I don't have a date set yet for it but please email me if you have interest in your local, and that will actually be a Lotus Training that is focused specifically on women who are 50 and over. We're wanting to really tailor our service provision for that age group right now. So that's one opportunity to be involved. And then we actually are also hiring an outreach coordinator right now, and we really emphasize hiring women living with HIV or people living with HIV in our hiring. So that's one position that we have open right now.
Thank you. How about at the Open Door?
Yeah, so we actually have a support booth at the Positive Health Clinic in which I facilitate, and I think that would be a good way to get involved. Also to seek out motivational interviewing as far as being able to get successful answers and connecting to other residents who are not in care.
Yeah, we're not actively hiring currently at our agency, but there are several agencies in Pittsburgh area that work specifically in the field of HIV and with peers, and there may be positions available there.
Okay, thank you. And we do have quite a few questions and answers left. What I'm going to do is make an executive decision that I am going to make a list of these questions and see which ones I can get answered kind of offline when we're done here, and we will distribute the answers later when we write everyone to thank them for their participation and let them know that the recording of the webinar is up, because I do want to respect everybody's time, and we agreed to end at 3 o'clock. So let me do this too. Here's contact information for one person from each organization so that you can follow up directly with folks if you'd rather do that, or if you'd like additional information. And I would really like to thank once again all of our presenters and thank all of the folks who decided to take time out of your day to join us today, and we hope that we will see you again, so to speak, on a webinar soon. Take care, thanks, and good afternoon to everybody.